And it is my pleasure to participate in the scientific session on Diabetes India 2021. At the outset, I would like to thank Dr. Banti Shabu and his team for giving me this excellent opportunity to be with you this morning to talk on a case report of diabetes and dyslipidemia. Actually, a 29-year-old gentleman contacted me for the problem of type 2 diabetes with a history that he had been taking metformin 1 gram twice daily. He lost his father at his 47 years of age. His BP was 125 by 83, 878.7 centimeter. BMI was 22. There was no corneal arcus. There are no xanthelasma or xanthomata. The normal cardiovascular system examination. His lipid profile, total cholesterol 286, LDL 220 milligrams, HDL 35, triglyceride 210, lipoprotein little a 60 milligrams. Fasting blood sugar levels were 120, HbA1c 6.9, TSH levels normal, creatinine normal, ALT, AST normal, urine analysis nothing specific. So this 29-year-old gentleman who is a diabetic and non-smoker with a strong family history of premature coronary artery disease and death, father died at the age of 47. He has all lipid abnormalities in the form of one, high triglycerides, higher levels of LDL cholesterol, higher levels of lipoprotein A, and low levels of HDL cholesterol. Actually, I strongly recommend it, even for my students who are actually under me. Every time when you see a patient with a dyslipidemia, you need to rule out secondary causes for dyslipidemia. Which I did it was normal. So this patient, in fact, I calculated the true LDL cholesterol. What is true LDL cholesterol? Normally, the lipoprotein little a contributes some amount of cholesterol to the LDL. So it is normally expected about 1/3 of the LPA contributes the cholesterol to the LDL. In our patient, the LPA levels is 60. So 1/3 of that is 20 milligrams. So 20 milligrams should be subtracted from the LDL levels, what we had seen. It comes to about 200 milligrams. It was a direct LDL cholesterol which was measured. Non-HDL cholesterol is the one. Total cholesterol minus HDL cholesterol gives you that number. And in our patient, it is 262 milligrams. Having seen this is the most interesting one which I thought I should project. This is a family pedigree of this particular individual, proband. We have seen that this gentleman has got total cholesterol high, triglycerides high, HDL is low, lipoprotein little a 60. Proband is the patient. Now look at the father who also had total cholesterol high, triglycerides high, HDL levels low. The LPA levels were not available at the time when the patient lost his father. And another one, the uncle. Uncle also the same, total cholesterol raised, triglycerides raised, HDL was 28, and lipoprotein little a only 5. The paternal uncle also had coronary artery disease at the age of 53 years. And now look at the mother. Mother is actually normal, but she is a diabetic. Total cholesterol is 160, triglyceride is 80, HDL is 35, lipoprotein little is 10. Look at the problems with the sister. Sister, she is a diabetic. HbA1c is 8.9 uncontrolled. LDL cholesterol is high, 143. ApoB is 133. She also has one total cholesterol very high. Triglyceride is very high. HDL is low. Lipoprotein little a is only 6. Having seen this, let me also tell you the proband, our patient, also has, in addition to the LDL cholesterol, he also has the ApoB, which is very high. I think this particular family pedigree has given me a lot of diagnosis in my mind. One, can this be a case of familial hypercholesterolemia over and above type 2 diabetes? Number one. Two, familial hypertriglyceridemia. Number two. Number three, familial dyslipidemia. So, first of all, let us look at familial hypercholesterolemia. This can be, FH can be one homozygous, number two, heterozygous. Homozygous occurs commonly in children, and of course, the very, very rare to get it. Pendant xanthoma, xanthelasma, all those markers will be identified by you, very easy to make a diagnosis. Heterozygous, probably around the age of 30 or so, they may get into problems of coronary artery disease, and they may not get the extreme longevity. Probably most of them will succumb by the age when they reach about 50 years or 55 years. So LDL not necessary that it should be elevated in all patients with a familial hypercholesterolemia. That's the most important point. But in our patient, the LDL cholesterol is very high. So everything fits in with the familial hypercholesterolemia. But surprisingly, he's not having a corneal arcus. He's not having a xanthelasma. He did not fit into the other categories of CASH criteria or the Simon-Brome criteria. But one thing that I should tell you is that LDL cholesterol is abnormally high. If any LDL cholesterol is more than 190 milligrams, you need to think in terms of a familial hypercholesterolemia. That's most important message what I thought I should share with you. Number two is a familial hypertriglyceridemia. Usually such patients will have abnormal elevation of triglyceride, but the LDL is usually low in such individuals or low normal. But in our patient, it is definitely raised. So it is quite unlikely to be only a simple case of familial hypertriglyceridemia. The third one, familial beta lipoproteinemia. Again, they will have the skin markers. It is not there. It is usually an autosomal recessive disorder. ApoB is usually normal, but in our patient, ApoB is high. Cholesterol is seen in larger particles in the VLDL and ideal range. So these three things which I had highlighted, probably hypercholesterolemia could be one diagnosis, familial heterozygous, but over and above, we need to explain the hypertriglyceridemia also. So this patient not only has familial hypercholesterolemia problems, in addition, he also has a hypertriglyceridemia. So let us think about this particular diagnosis, that is familial combined hyperlipidemia, FCH. Now we'll go back to the family pedigree. Look at the proband, which I have already highlighted. All these problems. One is the total cholesterol, LDL cholesterol raised, ApoB is raised, the HDL is low, the triglycerides are raised, and the lipoprotein little a in our patient is 60. That is one important information. Number one, the proband, that is a patient. Look at the father's problem. He also has total cholesterol, triglyceride raised. So that means he comes under the category of familial combined hyperlipidemia. Over and above, the father's lipoprotein little a was not available. He did not get any sort of report from the father's records, but I can probably presume that his father would have had lipoprotein little a levels, which is probably around 50 and above, because mother is not having it. Mother is having only 10 milligrams of lipoprotein little a. That tempts me to think in terms of a higher levels of LPA father would have had. That is why this patient, proband, is probably now having increased levels of lipoprotein little a. Look at mother. Mother has got only diabetes. All other parameters here are normal. Look at the sister's problem. The sister has got an uncontrolled diabetes. She has got high triglycerides, high cholesterol, low HDL, but the lipoprotein little a is low. Look at the paternal uncle. Paternal uncle, which I have already informed, that the patient has got a familial combined hyperlipidemia. So familial combined hyperlipidemia is seen in the paternal uncle, father, proband, and sister. All of them are having the familial combined hyperlipidemia. Over and above, this patient also has an increase in the lipoprotein little a, which is not seen in the paternal uncle, which is not seen in the sister, which is not seen in the mother. Probably father would have had because it is an autosomal dominant recessive inheritance. Having seen this, let me try to tell you something about familial combined hyperlipidemia. It is an autosomal dominant pattern of inheritance with elevated cholesterol, one, or elevated triglyceride, or both. Usually, VLDL and the LDL cholesterol moderate to severely elevated, and the ApoB is always elevated. In our patient, everything is now fitting into the diagnosis of familial combined hyperlipidemia. Over and above, he also has an elevated lipoprotein little a. It is again autosomal dominant trait determined by the quality of lipoprotein antigen. Now, if you want to propose the problem underlying, could be a monogenic hypothesis can be entertained for this familial combined hyperlipidemia, where there is an excess production of VLDL cholesterol from the liver, which is probably having a lot of ApoB particles also. When it goes for degradation in the form of LDL remnants, VLDL remnants, they attack the LDL cholesterol, which becomes smaller and dense, precipitates an event. The VLDL remnants also crushes back to the liver again to go in a cycle. So this is called monogenic hypothesis, which can explain the familial combined hyperlipidemia. So when you look at the data available, you can see that 1 to 2% of the general population. I want to impress upon you that we should not miss cases of familial combined hyperlipidemia. 1 to 2% of the general population. It accounts for 30 to 50% of the familial causes of CHD and 10% of premature CHD. Again, the patient's father died, probably would have died only due to a problem of a combined hyperlipidemia. So it can present as hypercholesterolemia or it can present as hypertriglyceridemia or both. Variable presentation even within a given family. That's what we have seen. One patient is having only the lipoprotein over and above, rest of them are all not having. Increased relative risk for coronary artery disease 1.7. It's thought to be a genetic complex disease, usually need co-inheritance of 2 plus genetic variants and affecting the lipoprotein metabolism. All along, we have been thinking that it is a monogenic hypothesis. The recent data, which was published only in the month of November last year, 2020, it gives you some indication about the characteristic abnormality seen in familial combined hyperlipidemia. Combined hyperlipidemia is usually genetically similar to hypertriglyceridemia. Combined hyperlipidemia and isolated hypertriglyceridemia share a polygenic basis, not a monogenic, polygenic basis through a common TG racing variants. An excess of common or rare genetic variants of LDL was absent in combined hyperlipidemia. So elevated LDL levels must be maybe due to unmeasured environmental or the genetic factors. This is the explanation that has been offered by the National Lipid Association statement, which was released in the month of November 2020. Having seen this, ladies and gentlemen, my patient is having a very high risk problem because he has got higher LDL cholesterol over and above the total cholesterol, which is high triglycerides, low HDL, and increased lipoprotein. He's a diabetic. He has got a family history of coronary artery disease and death. Almost all his family members are affected with the problem. So he comes under a very high risk group. Our data from Lipid Association of India in the way back in 2016, we came out with the first recommendation saying that we should keep the levels of LDL cholesterol less than 50 and non-HDL cholesterol should be less than 80 in very high risk group of individuals. In fact, in 2020, last year, we came out with another recommendation for managing lipids in our country. In this, we have also included that lipoprotein A more than 50 milligram is considered as a very high risk feature. Between 20 and 49 is considered as a moderate risk, non-conventional risk factor as per our recommendation. Whereas in 2016 itself, the first recommendation, we came out saying that non-HDL cholesterol should be considered as a co-primary target in ASCVD prevention. What I would like to tell you, we were the first organization, Lipid Association of India was the first organization to come out with a recommendation that very high-risk individuals should keep the levels of LDL cholesterol less than 50 milligram. Only in 2019, the ESC guidelines came up with saying 55. ASC comes out with 255 for a very high risk. Whereas in 2016 itself, we started coming out with the recommendation that it should be less than 50 milligram. Having seen this, I should also tell you, since our patient is also having hypertriglyceridemia, maybe that non-HDL cholesterol becomes a primary target. But we need to consider the evidence. We need to concentrate on LDL cholesterol first, and next concentrate on the non-HDL. For our patient, non-HDL cholesterol should be less than 80. Of course, we should emphasize diet and other modifications, particularly the therapeutic lifestyle changes to be emphasized again and again to our patient. Of course, the sister's blood sugar need to be controlled. Sister's triglyceride need to be controlled after controlling the sugar also. The therapeutic consideration for my patient will be statins at a very high dose, which I started, 40 milligram of rosuvastatin. And that did not bring down the LDL cholesterol to the satisfactory level. Then I added acetamide also. So aggressive lipid lowering is a must in this patient because of the strong family history. Of course, triglyceride should not be neglected. He has to be probably given some importance for the reduction. Where is the evidence for acetamide? All of us know about the IMPROVE trial, which has shown the way for us to add a non-statin drug like acetamide over and above the high dose or moderately higher dose of statin, which can be tolerated by a patient. You can always bring it down to the levels particularly these patients who were diabetic, they were able to bring down the LDL cholesterol to 46 milligram, which resulted in the reduction of 24% of MI, and ischemic stroke came down by 39%. You can look at the Kaplan net curve on the left side. You can just see 5.5% the absolute risk reduction that has been seen in those people who received acetamide plus statin in diabetic persons. Having seen this, you have reduced it, but you have not gone to the levels which we want, which is 46 milligram. Actually, it's 46 milligram, we can reach it, but in our patients, it's not possible because levels are 220. Not possible to reach that level. So that means I need to go again to another drug, that is PCSK9 inhibitor. That is the evidence. You can look at this particular data on the left side. Compared to the non-diabetic people, people with diabetes also have shown good amount of response. Whereas the 14.4% of diabetic individuals, in spite of reaching levels of less than 30 milligram, they were at a high risk of developing a residual risk. That means you need to concentrate on triglyceride. Where is the evidence to add any drug for triglyceride reduction at the same time getting a benefit? So far, we have not got any sort of evidence, but luckily, we have now got the evidence from reduced trial, which has shown icosapent ester given 2 grams in the morning, 2 grams in the evening, had benefited these patients who were diabetic with a higher levels of triglyceride, with almost normal levels of LDL cholesterol in the long follow-up, had resulted in about 25% reduction in the primary endpoints and 26% reduction in the secondary endpoints and 20% reduction, 26% reduction of cardiovascular death, which had been identified in reduced trial. Of course, now the criticism has started coming up with the reduced trial, which we can probably discuss it during the panel discussion. PCSK9 inhibitors, ladies and gentlemen, has shown us the best way of managing lipids. For my patient, I think is an ideal candidate to take PCSK9 inhibitor because it not only reduces the LDL cholesterol over and above whatever has been seen in the high dose statin plus acetamide, which you are not able to reach, put the patient on a PCSK9 inhibitor. It not only reduces the LDL, reduces the VLDL, remnant lipoproteins, LDL numbers comes down, non-HDL cholesterol comes down. And because when you concentrate on non-HDL cholesterol, if you're bringing it down, that means it subsumes all the bad effects of triglyceride. The lipoprotein little the only drug that has shown 25% reduction of lipoprotein little has been seen with the administration of avalokamab and alirocumab in studies. But it is not being recommended now. But what has been witnessed in the studies tells me that it is a potent drug, not only to reduce other abnormalities, but also lipoprotein little, which is the problem in our patient. Now, the bempedoic acid, it is yet to arrive our Indian market. It has been recommended, FDA approved drug over and above the statin drugs, over and above stigma. You can use this drug in those patients in whom you are not able to reach the goal. And it is probably indicated for patients with heterozygous familial hypercholesterolemia. Probably our patient can also be benefited if that drug arrives into the Indian market. Okay, if you have gone to the text, you need to know what is in the pipeline. Inclisiran is another drug. It is a small interfering messenger RNA interfering drug which can probably suppress the PCSK9 levels, which is beneficial for patients with this sort of abnormalities. So inclisiran probably will be helpful in due course in the years to come. So, ladies and gentlemen, this is my last slide. Statins are the best drug. Statins are safe. Statins are efficacious. If you give a high dose statin, you will definitely get a good result. If you are not able to reach the goal in your patient, having given a high dose, which each patient can tolerate, then look for another drug, non-statin, that is acetamide at 10 milligram. You may get only about 15 to 20 milligrams reduction of LDL cholesterol over and above statin. But when you use a PCSK9 inhibitor, nearly 60% reduction of LDL cholesterol can be achieved. That's the only drug which is available in our country, which I actually had given the prescription for my patient, for which he is not willing to take it because of cost factor. Of course, I need to wait for the bempedoic acid to arrive into the market. We need to wait for the icosapent ester to be used in our patient with hypertriglyceridemia. Of course, time is not far off to witness the introduction of inclisiran in the place of PCSK9 inhibitor because it becomes cost effective. We can use it only twice a year. whereas PCSK9 inhibitor every month, whereas inclisiran can be used twice a week. Thank you very much, ladies and gentlemen, for patient listening.